Hello.
Yeah, yes. Yeah, I will start in
Sir,
yeah.
yes, if you can start the session, the room is open.
Okay, I'll start in 1 minute time. Yeah.
Okay, sir.
Okay. Okay. Smita, shall I start? Okay, good evening to all of you. I will share my screen. Okay, I will start with the short case first. Can you see my slide, please? Can you see my screen? Hello?
Yes, sir.
Yeah, right. Okay, right. So first with the story of a 23-year-old male. 3 weeks back, when he got up from bed, he noticed abnormal posturing of his middle two fingers of the right hand. Prior to that, he has no complaint. He was sleeping as usual in his own bed. No history of any sleeping outside the court. He also noticed some numbness of the medial palm. No other relevant history. Next, okay. So this is not the right hand, sorry, the left hand. Notice abnormal posturing of the left hand. This is the abnormal posturing of the left hand. His middle two fingers is flexed in the interphalangeal joints. There was no pupillary abnormality. Pain levels are all normal. Upper limb deltoid normal, triceps normal. This is the posture of his left hand. Wrist extension normal. He has got clawing of the middle two fingers. The intrusive is normal on the right side, weak on the left side. Palmar abductor digitum is slightly weak, not weak as other muscles. Intrusi temporicals were weak. Abductor pollicis longus is normal bilaterally. Flexor pollicis is normal, but flexor pollicis brevis is weak. See, his thumb goes into flexion, distal goes into flexion when you do the flexor pollicis brevis, indicating that on the right side it is normal. The distal phalanx does not go into flexion. On left side it goes into, indicating flexor pollicis brevis is weak. Opponent is also mildly weak on the left side. The FDI is weak, so the ADP is also mildly weak. The common sign is positive on the left side. Palmar intrusive is normal on the right side, weak on the left side. There is no nerve thickening in the ulnar nerve. The reflexes were normal. Of the sensation, he said that there is some difference in the left middle aspect of the, he's showing that area. That area is little less compared to the other side. But there is no difference in the medial and lateral aspect of the ring finger. That area is telling us a numb on that side. That area is pointing it out. ഈ പെരുപ്പ് മാറി നോർമൽ ആകുമ്പോൾ പറയാം. When it become normal, that area he said is become normal. Okay, on examination, weakness of all intrusive, flexor pollicis brevis to the left hand, left thumb. Opponent's ADM appear also mildly weak on the left side. Adductor pollicis also is weak. Rest of the muscles of the left upper limb normal. DTR all normal. Sensory dulling in the left little finger and the medial part of the left palm. Other areas are normal. No nerve thickening. So it's a short case. What is the diagnosis? Straightforward case. What is the diagnosis?
Sir, lower trunk brachial flexopathy, sir.
Lower trunk brachial plexopathy, but his weakness is confined to the supply of ulnar nerve. Where do you want to think of lower trunk brachial plexopathy?
Sir, dorsum of my normal, sir.
Pardon?
Sensory supply over the dorsal last two fingers normal, sir. 1.5.
Okay, that will come later. That it seems normal.
Sir, patient has weakness of both opponent's pollicis, flexor pollicis brevis, which is also a part of median nerve supply, sir.
No, flexor pollicis brevis can be supplied with the ulnar nerve also.
Opponent's pollicis is chiefly by median nerve, sir.
Correct. Opponent's pollicis is by median nerve only. But when you do the opponent's testing by opposing the thumb and the little finger, the opponent's pollicis as well as opponent's digitiminea both will contribute. Okay, if either of them is weak, you will be able to oppose the little finger and the thumb. So I think go for a straightforward with ulnar nerve palsy. The question is, where is the site of lesion in this patient with ulnar nerve palsy? That's the question. He noticed one day morning when he got up from bed. No pain, nothing. And where is the site in the ulnar nerve and what's likely etiology?
So if
Sir,
it is
I
only
put
the ulnar nerve, then
Pardon?
the lesion probably. So we have to test for wrist palmar flexion, sir. How about the ulnar deviation? Ulnar.
Okay, very good.
Ulnar.
That's okay. So that's the thing I wanted to tell because you have to look for to find out the site of his ulnar nerve, whether it is in the elbow, whether distal to that in the wrist. You have to do the certain things. So if a nerve conduction was done, I'll show the way it has been done in the hospital. So nerve conduction is normal, the left ulnar nerve, normal amplitude. See, CMAP amplitude. These 3 weeks. And left median FAV is normal, ulnar is also normal. Sensory also is normal. So what do you think?
Sir, FDA, sir. FDA pickup, sir.
FDA pickup. Yeah, you're all correct. Perfectly right. You're thinking the same way I was thinking about. So as the doctor was telling, you have to check the flexor carpi ulnaris first. So flexor carpi ulnaris was examined. That is on the right side. That's the affected side. It is normal power. Again, telling you more likely the lesion is distal to the elbow. So what else you need? Examine the dorsal aspect of the sensation. ഈ കുത്തുന്നതും ഇതും തമ്മിലോ ഒരേ വ്യത്യാസമില്ല. There is no difference in the pain. ഒരേപോലെയാണ്, വ്യത്യാസമില്ല. Okay, now where is the site of lesion?
Sir, after
Pardon?
just above the palmar branch, sir. In the
Okay. What is the site you can call that? The particular site?
Guyon's canal.
Yeah, proximal Guyon's canal, correct. So what will you do now to confirm your possibility of Guyon's canal involvement? The dorsal ulnar cutaneous nerve potential is normal on both sides.
Ultrasound, sir.
Okay, that's what to find the structural lesion there to find out the site. Yes, somebody was telling correct
FDA
previous.
pickup, sir.
That's answer. Okay, They already came with imaging technique. So what you have to do is that, and see the hands once again, is severe, he's got a wasting of the introtia and deformity. But look at the palmar surface, the abductor digit, I mean the hypothenar muscles not at all atrophied, almost normal, even though he has got wasting of the posterior introtia. So no wasting of the hypothenar muscles. Then we did a pickup from the FTA. There is no potential picked up from the FTA. That tells you what? That conclusively tell you that lesion is in the Guyon's canal. Because the nerve is affected distal to the supply, its hypothenar is also affected to a little extent. Main affection is distal to the supply of the hypothenar muscles. That means in the Guyon's canal. So always when you have a normal contraction in the FDI, so in the ADM from the hypothenar muscles, always check for from the FTA also, which you often do not know. So this case is only brought to highlight the point that try to localize where the nerve is affected. Then only you can investigate further. Suppose you localize the elbow, you need an ultrasound of the elbow or a MRI of the elbow. If the lesion is in the Guyon's canal, you need an MRI of the wrist. So that part, that's the idea that is the idea behind the correct localization. So what are the tests you need now? You localize the Guyon's. Yeah, you got MRI of the wrist. Yeah. Better than ultrasound, MRI, the wrist, Guyon's canal, MRI is ideal. I did an MRI of the wrist, but unfortunately there is no lesion in the MRI. The most likely maybe some kind of a neuritis rather than a focal structural pathology. Moreover, it is acute in onset, not a chronic one. Again, the picture is not good quality. There is no lesion in the Guyon's canal. Okay, so it's a straightforward case. Then I'll just tell you a few points regarding the types of nerve involvement in Guyon's. So there are 4 type pattern can occur. The tunnel is formed by the transverse carpal piezohamate ligament, the tendon of the flexor carpi ulnaris muscle, and the pisiform hamate bone. The tunnel contains a palmar branch of the ulnar nerve. The palmar branch divides into superficial and deep palmar branches that pass through the tunnel. So this is the Guyon's canal. You can see the picture here. The superficial division of the palmar branch innervate the palmaris brevis muscle, the small one which is in the middlemost part, and the palmar 5th digit and ulnar aspect of the 4th digit sensory supply. That is supplied by the superficial division. Now the deep branch innervates the hypothenar, the proximal part of the deep branch supplies the hypothenar muscle, and the 2 most lateral umbilicals and the introtia and adductor pollicis, and deep head of the flexor pollicis brevis. That is the deep, that is a deep branch. So this is the again picture, another picture with the 4 different patterns. This is ulnar, this is the square is the ulnar, the Guyon's canal. This is superficial sensory division. We supplies the palmaris brevis and the subcutaneous supply to the medial 1.5 fingers. Then the deep branch, we here gives hypothenar motor supply to hypothenar. Then the deep branch comes. Okay. So there can be, depending upon the site, you can have various types. The one, if a deep branch alone is affected, here distal to the Guyon's canal, you get only affection of the introtia and adductor pollicis, and often it can be confused with motor neuron disease. They come to with a small muscle wasting and weakness and everything. And if there is no sensory at all, it may be confused with motor neuron disease. You should keep in mind, rule out a deep branch of the ulnar. With lesion is more proximal, again, you can mimic this thing, motor neuron disease. Here, the hypothenar is also affected, but the sensory is spared. It's more proximal lesion before the origin of the nerves which supply the hypothenar muscles. That is a proximal motor lesion. Then you can have a proximal lesion, the Guyon's canal, where it all can be affected, including the sensory of the or the middle part of the palm, that just like our patient had. Sometimes only sensory alone may be affected, where motor can be spared, where the sensory branch from the ulnar nerve is affected. These are the 4 types of lesion in the Guyon skin. Okay, so any questions before I go to the proper case? No questions, no? Okay.
Awesome.
Yeah. So next I'm going to show you a case. It's a little tough case, mainly for ocular movements. The various types of abnormality there, which is fine to you to decipher it out. Now, this is a story of a 50-year-old man. His story started 20 years back when he was diagnosed to have tuberculous meningitis. He was admitted in the hospital. He was comatose for about 2 to 3 weeks. On recovery, he noticed diplopia, which is vertical, and according to him, it is more on looking up and to the right. It also polyuria and polydipsia at that time, and was later found out that he had diabetes insipidus, probably sequelae of the tuberculous meningitis. He has now come with 2 complaints: persistent diplopia and dizziness, most likely due to diplopia itself, and burning pain on the left side of the body. Maybe some infarct has occurred at that time. Now, I have brought this case after analysis ocular findings alone. Now, I am showing the full video first, then I'll cut it into many pieces, a fragment of the video to highlight the key findings. So in each step, I'll be asking questions regarding what could be the abnormality. I will show the full video first, once I from the very beginning. This is the primary position. I'm asking to look up. Ask him to look to the right side. The left side. Looking up. Up and to the left side. Down and to the left side. Straight down. Looking laterally to the right side. I'm doing the pursuit movement now. I'm going to follow my finger. Okay. So it's very difficult to analyze the ocular movements now. There's many things in this patient. So I'll let me break up the video into many parts for analysis of each abnormality for the simplicity's sake. Now let's first show the first part of the video, this alone, and get your opinion. He's asked to look straight. Looking at the finger. Now, what abnormality did you notice?
Left eye is deviated laterally.
Yeah, left eye is deviated laterally, so the mild exotropia. Very good. Anything else?
Sir, right eye is up and left eye is down, sir. There is also a part of...
Right eye is up, left eye is down. Very good.
His upper sclera is also visible.
So what is that called?
Collier's sign.
Okay, that's a Collier's sign. So here I'll come to the ocular movements later on in detail. As you all said correctly, it's got a mild exodeviation on the left eye. Right eye is up, left eye is slightly down. And it's got a sclera is visible. So that's got a Collier's sign. So where is the site of vision for the Collier's sign?
Dorsal membrane, sir.
Okay, dorsal midbrain. So can you believe what is happening in the dorsal midbrain to produce Collier's sign?
So there is there are 4 components of dorsal midbrain syndrome. So usually in a Baronow's syndrome, we'll get a upgaze restriction. There will be eyelid retraction with light near dissociation. That is, a patient will have a reaction to light, but near reaction of pupillary constriction will be absent. And fourth one is, I forgot the fourth one. Sir.
Okay, so I'll come to that one by one. What is it is correct. But I want to know how Localization is produced. Why the retraction is occurring in the dorsal midbrain. So to that, I will see this one. There are a group of neurons called M neurons in the dorsal midbrain. The purpose or function of which is to coordinate the eyeball and lid contraction. Suppose when you move the eyeball up, the eyelid invariably moves upward. When you move the eyeball downward, the eyelid follows the eyeball, correct? So there must be coordination between the eyeball vertical movement and the lid movement. And that is done by these M neurons. So it has got a connection with the caudal central nucleus, which is the one responsible for the eyelid contraction. And the third are subnuclei concerned with the vertical movements, superior rectus, inferior oblique. So it coordinates the vertical eyelid movement. And this M group of neurons are influenced or mediated or driven by what is called a nucleus in the posterior commissure. And here, if there is a lesion here in this pathway here, so the input on the nucleus of posterior commissure to the M neurons is lost, and that is responsible for the Localization. That is why in dorsal midbrain lesion, you get a lid retraction. Okay. Now, next one. Before I ask you how to differentiate Localization from that of lid lag due to thyrotoxicosis.
So there will be proptosis, sir.
Yeah, there can be other features of the thyrotoxicosis. But this lid retraction alone at any point.
So frontalis overactivity.
No, why should frontalis overactivity occur? Lid is already retracted. If there is a ptosis only, frontalis should become going to hyperactivity. In ptosis, to overcome that, to elevate the eyebrow, you try to elevate the eyebrow and get frontalis hyperactivity. The point what they say is that in case of thyrotoxic dose, there is a lid retraction as well as a lid lag. Whereas in Localization, there is lid retraction but no lag. For example, if you ask the patient to bring down the eyeball, the eyelid will come down. No lag will be there in Localization. But the other thing, there is a lag also because of the restrictive pathology, restrictive orthogonopathy, the muscle is not relaxing. Anyway, that's only away from our patient. Now, I will show the second part of the video. The first part, okay, you said called correctly. Now, let us see. Then, ask him, looks straight. What all things you observe? I'll show the video once again. Look at normal movements now. Any suggestions?
So this is on
But you couldn't get the video once again. What did you say?
Sir, this is on looking straight or down, sir?
Yeah, no, this is only looking straight.
On looking
Sir, the
straight,
eyeball.
persistent skew deviation, sir.
Okay, right. One is correct. Perfectly what you said is correct. One is high, one is down. Perfectly right. Then any involuntary movement you did not
Yes,
do.
a downbeat nystagmus is there.
So it's coming inward, down and in.
Downbeat is correct. Look at the vessel on the sclera on the side.
Torsional component, sir.
Now, there is a torsional component and hardly any vertical component at the right time. I'll show once again. I think I put a stone messy. I'll show the video once again. Maybe I look at the right eye, only torsional component is the left eye is torsional component is bringing down also, some downbeat component also, only confined to the left eye. I told you before, this is a really tough case. Okay? So there is a torsional nystagmus. Torsional component is at both eyes, and which direction is moving, clockwise or anti-clockwise, the first component. We tell the nystagmus direction is the one, I mean, we say right, the And the fast component is the one which gives the direction of the nystagmus. It's named according to the fast component. When you say nystagmus to the right side, we mean fast component on the right side. In the case of torsional nystagmus, we say anti-clockwise or clockwise. In term, the clockwise and anti-clockwise in relation to the person, not to the person, but the examiner who is the patient. Suppose you are seeing his left eye rotating to the left side, that is clockwise. If it is to the right side from your side, it is an anti-clockwise. You got the point. From the patient side is different from your side. What you perceive, the rotation, that is the clockwise and anti-clockwise. That is the one you have to tell. So you see the video once again. Look at the right eye very carefully.
Clockwise, sir.
Right, it's a clockwise fast component. Okay, so when clockwise is the fast component, the pathological component is the slow phase. The slow phase is anti-clockwise. That will come. Pathophysiology will come later on. So this much you have said this correctly. It's got a clockwise rotational fast component, clockwise rotational nystagmus on both eyes. Then he has got one eye is down, one eye is up. Okay. Well, let us see now. So yes, you see his left eye is lower compared to the right. It could be due to the weakness of the elevators of the left eye, or due to the, sorry, I said wrongly. It is elevated left eye or depressors of the right eye. I typed it wrong. Or it's a skew deviation, right? So how to differentiate whether it's a skew deviation or is a weakness of elevation of the one eye or not?
So make him to lie down. The graviceptive pathway will eliminate, sir.
Okay, that is VOR cannot help because persistently abnormal.
So then usually,
making them lie down can help sometime, but not all the time. Because the problem, and I'll tell you when you explain the mechanism, you'll understand that thing. Okay, we'll stop it at this level. So it could be either. It can be skew deviation, more likely skew deviation. Suppose you find that elevators are normal otherwise, that tell you it is not infranuclear due to elevator paralysis, correct?
yes.
So
Sir.
let us see. Yeah. Now let's see what is the type of nystagmus that I will come later on. Now I'll show it in slow motion again. Same thing. I forgot. I got to look in slow motion also. See the rotation compared to the right eye and the down and rotation of the left eye. Okay, so he has got a rotary nystagmus with fast component clockwise, and the left moves along with the rotary component. Moves down along with the rotary component, not the right one. The right only pure rotary, left one rotary plus downward move. Okay, this is what all of you have said correctly. Now, where is the lesion for this rotary nystagmus?
Sir, usually when on attempted upcase, when the patient has a torsional nystagmus, we can localize a lesion to nucleus of posterior commissure, sir, NPC. But here, when looking straight itself, the patient has a torsional nystagmus. Still, we can localize it to the midbrain itself, sir.
It can localize the midbrain. I want to say that. See, this rotary nystagmus can occur anywhere from the vestibular nucleus to the extraocular muscles. Okay, so I will come to that later. That I'll explain later. Before that, I'll tell you the pathway. It's little difficult to comprehend, but then you will understand. Okay, why it is occurring. Right. Now, third video. Look at the third video now. Looking up. His eyes are not moving up at all. So what is he having?
Upcase palsy.
It could be upcase palsy, or it can be weakness of elevators of both eye. due to element palsy itself. Say, suppose I say it's got a weakness of the superior rectus and inferior oblique of both eyes. Same thing can occur.
Maneuverability, sir.
Maneuverability means what? VOR.
Yes, sir.
One is VOR, very good. Then second thing is
Bit nystagmus is there, sir.
nystagmus is different. What I'm trying to say is got a failure of elevation of both eyes. It can be due to LMN or due to gaze palsy. So how to differentiate? One is if you can get VOR by when the eyes are moving up, it's one way to differentiate. The other way is what? This method which I did. How to differentiate?
Okay, and
So
all,
look
sir.
at what did I do? Bell's phenomenon. You ask him to close right, the eyeball rolls up. Did you see that? Looking up. Now I'm closing, the eyeball rolls upward. Indicating what? If it is an element paralysis, the Bell's phenomenon will be absent invariably because it is not moving up. So here the eyeballs are moving and closely indicating that he has got a gaze palsy looking upward. Okay. Right. So that tells you that the vertical separation is not due to the weakness of the elevators, asymmetrical weakness of the elevators. So it has to be some supranuclear compound, that is a skew deviation. Now, on doing Bell's phenomenon, the eyes roll upward, such as the gaze palsy. Now, where is the site of lesion for that? Upward gaze palsy?
Dorsal midbrain.
Okay, dorsal midbrain. Okay. In fact, it can occur with where is the pathway originating from?
NPC, sir, nucleus of posterior commissure. It goes to bilateral superior rectus, oculomotor nucleus, and then it goes to the.
It is not NPC. It is RIMLF, rostral industrial nucleus of RIMLF. That is the origin supranuclear burst. That is where the burst neurons for the upward and downward gaze is situated. I'll show the picture now. This is a red nucleus. This is where the RIMLF is situated on both sides. The vertical EBN or excitatory burst neurons project to both third and fourth motor neurons. For the upward gaze, what happens is that it goes upward, cross to the opposite side of the posterior commissure, and innervate both the third nuclei concerned with the upward movement. That is the superior rectus and inferior oblique on both sides. Similarly, from the other RMLF also, the fibers go posteriorly, cross to the posterior commissure, and supply both third and subnuclei concerned with the upward. Correct. So if you got a lesion here, so suppose lesion on one side, one RMLF will not produce an enduring upward gaze. They said upward gaze palsy can occur, but only transiently because the other fellow will compensate. An enduring or persistent upward gaze palsy indicate a lesion of the posterior commissure where the fibers from the RMLF on both sides are cut, are compromised. I will show the picture next time. So, unilateral lesions of RAML cause a mild deficit in vertical saccade. Bilateral lesions are required to produce clinically apparent deficits in vertical eye movements. So, if there is a lesion here, it produces a persistent or enduring upward gaze palsy. So, that is the answer. So, you have a lesion there in the pretectal region. Now, let us see what was the type of nystagmus seen on looking up. Now, look very carefully on looking up. For that, you have to don't look at eye, look at the root of the nose to find out the abnormal eye movement. It is very subtle, difficult to see, even if you don't miss it around. Look at the root of the nose and look at the eyeball. How do you make out anything? Anything abnormality do you make out? It's got a convergence nystagmus. You've got a convergent retraction nystagmus. I will show once again with the, don't look at the eye, look only at the root of the nose, then you can perceive the movement. Did you see that? Converge a little bit. Anyway, if it's not obvious, keep that finding. Anyway, forget about that. Let us see the slow motion. Okay, difficult to make out the convergence, but you can make out very carefully. Yeah, see that now it's converging. It comes only when the patient attempts to look up, it will converge. Otherwise, it will not. Primary position may not occur. Only an attempted up case this will become manifest. Anyway, forget about that. Let us see the ocular movements. Okay.
So that convergence once more.
Pardon?
Once more, that convergence.
Yeah,
Sir.
I'll show them. Yeah, I'll show once again. Look at the left, especially the left side is little more clearly seen. See that? Now he's not looking up. Attempt look now. Now he'll come. See that. See that. See that now? Left eye. His left eye.
Sir, but only left eye is converging, sir. Right eye is remaining isotropic.
Because when you look at the right eye, you are not able to see the right eye. So that's what I want you to look at the root of the nose so that you can perceive the movement bilaterally. It will not see very focus, but only see some movement like that. Now look at the root of the nose now, don't get the eye, then you can see that both eyes you can see the moving. Very subtle on the right side, as I said, correct. Very subtle. Now forget about it, that's not very obvious convergent touch styles. Now let us see the ocular movement now. Look at the right side, full abduction. Full abduction and adduction. Upward movement is restricted as shown before. Looking down and to the left side. Looking straight down. What abnormality did you notice? Forget about the upward. I'll definitely. No. Look into the right side now. Look into the left side. See what happened to the adducting eye. Let us see the adducting eye.
Nystagmus in vomiting.
Nystagmus is there, but what's abnormal eye movement? Nystagmus we discussed earlier. Here nystagmus, rotary nystagmus, and the left eye is also in addition to a downward nystagmus also on one eye only. But what is this ocular movement telling you? But I will show once again.
Sir, right depression. Sir.
Right. Whenever you look to the one side, to the left side, the right eye adducts and goes down. When you go to the right side, the left and the adducting eye goes down. Okay, in both directions, the adducting eye is going down. If it is a skew deviation, it should be maintained in all directions of gaze. The left eye should have been, according to this one, initially what did you find? The left eye was down, right eye was up. That's a normal skew. That skew should be maintained in all directions. If it is a normal skew. Here the skew changes. For example, I'll show. I'll pause it. Wait. Did you see that? The left eye is down now when adducting position. Now I am showing to the right side. See, right side, what happened? The right eye is down now, not the left eye. Okay? Do you agree with that? Initially, left eye was down, now the right eye is down.
Yes, sir.
Whenever the eye attacks, this is called
Alternating skews, sir.
very good. This is called alternating skew. Okay, it is not a ordinary skew and alternating skew deviation. Now, with that in mind, you see the video once again.
ഈ ഡയറക്ഷൻ നോക്ക്, ഇനി ഇങ്ങോട്ട് താഴോട്ട് ഇവിടെ നോക്കി, അത് തന്നെ നോക്കിക്കോട്ടെ. ഇനി താഴെ നേരെ താഴെ നോക്ക്, ഇവിടെ ഇനി ഇവിടെ നോക്ക്.
Now, this is the one I'm referring to. Adducting eye goes down.
ഇതിൻ്റെ വിരൽ നോക്കിയോ, വെള്ളി തന്നെ നോക്കേ, വെള്ളി തന്നെ നോക്കേ, വെള്ളി തന്നെ നോക്കേ.
See that one now. Okay. Now, let's see the adduction movement, what is happening. Whether we got a doubt whether it's abduction failure or not. Downward movement appears quickly restricted on the left side. Upward movements are invariably restricted because got a gaze pulse. We've already seen that. So the initial exotropy which we observed was not due to paralysis of any lateral rectus or medial rectus. Okay, now, so lateral movements are full in both eyes. That's the thing you observed with the adduction movement, no restriction. Looking to the left, the right adducting eye goes down. Looking to the right, left adducting eye goes down. And what is this phenomenon? We already told. And possibly, if you find very carefully, the depression also restricted in both eyes. But that will not be very certain, but appears to be decreased. Suppose the depression is also decreased in both eyes, where could be the site of lesion? Correct. That means perfectly right. This was a bilateral RAML. So if bilateral RAML is produced, both elevation as well as depression will be weak, restricted. Only in posterior combination you can have upward gaze palsy. Okay. To produce downward gaze palsy, unilateral lesion will not produce downward gaze palsy. It should be lesion bilaterally from the RAML up to the muscles responsible for the downward movement of the eyes. So see once again, this is for same only showing that alternating gaze deviation. Okay, so this is called alternating skew deviation. It repeats also affects at least the RML bilateral, already said. Now let us see the pathophysiology skew deviation. Initially we told about the pathophysiology Rotary nystagmus and the skew deviation. So here you have to concentrate a little bit the pathophysiology, you know the pathway, how this is being maintained. And before that, what is skew deviation? Vertical misalignment of the eyes resulting from supranuclear lesions due to imbalance in the tonic level of activity underlying the otolith ocular reflexes. That is, the uticular macula is connected to the contralateral interstitial nucleus of Cahan. So what is the function of uticle and saccule is to maintain the position of the, mainly uticle, to maintain the position of the eyes in relation to gravity. Okay, just like your sense your body upright or not, that's the function of the uticle, as well as linear acceleration. So if there is a tonic activity from the uticle to the extraocular muscles, when that is abnormal, an imbalance is occurring, you get the skew deviation. Now let us see the pathophysiology of that. Cerebellum and the binocular oculomotor control. Cerebellum is involved in adjusting the relative position of the eyes during fixation, that is static alignment, and yoking of the muscle during movement, that's a dynamic alignment. Dysfunction of the disc control causes skew deviation. There is a vertical misalignment of the eyes that cannot be attributed to an extraocular muscle paralysis. So skew deviation means it should be supranuclear, not due to infranuclear. Suppose got a superior oblique palsy, I will be up, that you can't call it as a super thing. To understand this skew deviation, you must also know a little bit about what is ocular counter role. Ocular counter role is that when you tilt the head to one side, head to the right side, the eyeball rotate to the opposite side. That means when you turn the head to the right side, the right eye indot, left eye extorts. Why? Because when you are changing the position of the eyes to make it vertical. Otherwise, what will you see? If there is no counter rolling of the eyeball does not occur, you will see the image as all tilted. Okay. We are not seeing, suppose you're looking at a picture, turn the head right, you still see the picture is straight. This is because the eyes are also making compensatory rotating movement. The image falls exactly onto the macula. If the eyeball was not rotating, you would have seen the image also is rotated, tilted. So under normal circumstances, when the head is tilted to the left, the eyes will counter roll to the opposite direction. The upper poles, the eyes slowly move away from the side of tilt. That is, the left eye indots, the right eye extorts. Furthermore, a small skew or a vertical alignment also appears with hypertrophy of the indoting eye. Now, how this is occurring is because of the activation of the cyclovertical muscles. Cyclovertical muscles are the recti and the oblique eye through graviceptive pathway. When you tilt to one side, eyes make a rotation to the opposite side as told before. For example, a left head tilt results in counterclockwise with respect to the examiner, dorsal counter roll to the upper poles of the eyes. Now let us see, suppose this is a normal posture. Suppose you tilt towards the left side, left head, but what left to the right side, what will happen? The eyes will more rotate to the opposite side. So the eyes become vertically oriented. It will not go tilt along with the body. It will make a counter-rolling phenomena. This is the method by we used to test the Bielczewski's head rotation for superior oblique palsy. And let us see the graviceptive pathway. This is the graviceptive pathway originate from the otolith organ as well as superior semicircular canal. They end in the vestibular nucleus, cross to the opposite side, ascend in the MLF and connect with the INC for ocular counter roll, and goes to the thalamus and the parietal cortex for your perception of the verticality of the body, for that it will reach the cortex. So there is a graviceptive pathway. So it's connected to the not only extraocular nuclei, but also to the cortex of the thalamus. Now, what is the pathway? Now let us see the utricle. I do not know whether you require all these things, but when you read these chapters, it may be difficult to understand. So you can see this diagram, it make you easy to understand this thing. From the utricle, it goes to the vestibular nucleus. Okay. The utricle is connected to all the extraocular muscles, nuclei of the opposite muscle, nuclei of the extraocular muscles, the opposite side. Okay. That is superior rectus, inferior oblique of the third nerve, and superior oblique of the fourth nerve. Okay. Or just imagine that thing. What happened to the superior rectus and the inferior rectus and inferior oblique supply the ipsilateral mass? They are not crossed. Okay. They supply the same side. That is, right utricular stimulation will stimulate the left inferior rectus and inferior oblique. On the other hand, it will stimulate because superior rectus supply the opposite superior rectus, superior oblique also supplying the opposite superior oblique muscle. So ultimately, if you stimulate the right utricle, you get stimulation of the superior rectus and superior oblique on the same side, inferior rectus, inferior oblique on the opposite side. Okay, this much is okay. Now let us see what happens when you stimulate your utricle. When you tilt the head to the right side, that utricle is stimulated. So what that is stimulated? So what will happen? Imagine the right eye. Right superior rectus and superior oblique is activated. Superior rectus, what will both are indoters, correct? So superior rectus, superior both are indot, they will indot the eye. And the eye will also move little upward Even though superior oblique is a depressor, the superior rectus is a major elevator. Because both one is a depressor, one is a elevator, but superior rectus is a major elevator compared to the mild depression of the superior oblique. So the superior rectus takes an upper hand. So the eyeball move upward and rotate inside in dot. Okay, right. Now what happened to the left side now? Left side, there's in contraction, the inferior rectus, both are extortes, the eyeball will extort. And inferior rectus, inferior oblique, as far as regarding the vertical movement, inferior rectus is a major depressor. So what will happen? The eyeball will come down. Inferior oblique is a mild elevator. So the depression action will overtake the elevation action of the inferior oblique. So this is what is going to happen if you stimulate the utricle. Or when you turn the head to the right side, this is pathophysiology, the ocular counter rod. That is when you turn to the left to the right side, why eye is rotating and the left eye is rotating inside, while the other is extorting. So that is physiological rotation. So what will happen? The right eye, we stimulate it, right eye will goes up and indort, left eye will goes down and extort. The lower panel which you can see there. Now let us see what happens when utricle is affected. That means this is a vestibular. Before that, there are many things can happen when utricle is affected. One is ocular tilt reaction, which I'm going to tell now. It can also produce skew deviation. It can produce torsional nystagmus and tilt of the subjective visual verticality. And let us see the utricle is affected now with a lesion on the right side. So what will happen? The left fellow will overact. So what will happen? Instead of the right eye going up and indort, the opposite will happen. Okay, the right eye will go and extort, go down and extort. Left eye will go and indort. So as if the opposite utricle is activated. One side is affected, the other fellow will overact because there is always a constant stream of impulses coming in the utricle. So you get the opposite of what you got the stimulation. Okay, the same side of lesion, the eyeball will be down and extorted. The opposite side, eyeball will be up and indorted. That is what is exactly happening in lesions like utricle acid lateral syndrome. You get the same side eye will be down and extorted. The opposite eye will be up and indorted. This is how the mechanism of skew deviation is occurring. Now, what will you observe will be the head also will be deviated to the same side. By this is head deviation is not because of the abnormality, that is compensatory. But the pathology, the eyes is coming down. So to correct the visual disparity, you try to tilt the head to the same side to correct whatever is abnormality is there. So that head rotation is compensatory. This is same if there is lesions occurring in the here, lesions in the utricle, or in the pathway before crossing, or here, or after crossing. So if it's after crossing, of course, the deviation to the opposite side. Okay, because suppose you utricle is on the right side, this is the pattern. The same thing will also occur the lesions in the midbrain, but to the opposite side. Are you getting a point? Suppose you've got a right utricular lesion, that eye is down and extorted, left eye is up and indorted. If the lesion is the left midbrain, also you get the same thing. That ipsilateral eye will be up and indorted, and the other eye will be down and extorted, because the same pathway is operating. So this is called ocular tilt reaction. That is unilateral visualization produces ipsilateral chronic OTR. They produce skew deviation, circular rotation of the both eyes, and paradoxical head tilt. Paradoxical means you are not due to the abnormality, but you are compensatory making the head tilt to the right, to the lower eye. So OTR indicates dysfunction of the graviceptive pathway anywhere from the peripheral labyrinth to the INC, the rostral membrane. Now, the easy method to remember is that skew deviation is there's low, low, high, high. That means if the lesion is low here, the lower part, okay, that eye will be low. Right side lesion means right eye will be low. Okay. If the lesion is up here in the ML level, that eye will be up. Okay, easy mnemonic to remember is that low, low, high, high. Lower the lesion, that eye is low. Higher the lesion, the MLF, that eye will be up. So that is the mnemonic. So I think this I will skip. Now, how to look for skew deviation? Mild. This one thing is very, in this case is obvious. Mild vertical deviation, you have to make out alternate cover test. Then you will find when you move the cover from one to the other, I will move up and downward. This is the cover and cover test. Now, a little bit about skew deviation. Skew deviation can be competent and incompetent. Competent means that's the usual one. The vertical separation is constant in all directions of case. If you'd like to, suppose if one eye is up and down, in all direction it will be like that. Right, left eye, this eye will be up, this will be down, wherever you look. If it changes, it becomes incompetent. For example, our patients with alternating skew is incompetent skew. So the vertical separation is different in different positions of the case. And that one condition is what you could say is alternating skew deviation. That is, skew varies with the direction of gaze. One is hypertropic in one direction, the other becomes hypertropic in the other direction. The lesion is usually in the pretectal region, at least INC, but also can be seen caudal medullary lesion. So lateral alternating skew deviation results from bilateral injury to the central cavity pathways, which extend from the medulla to the membrane. Because these pathways can be injured at any point along this course, it should be expected that bilateral lesions at many positions along the brainstem can produce this ocular motility disorder. Okay. Right? So this much about the skew deviation. So any questions in that? Is it tough to understand?
Yes, sir.
Yes, sir.
Okay, then I think I'll skip the other things what I was planning to tell you was about the pathophysiology alternative skew deviation. That is a little more tough. I think I'll skip that part.
No, sir, please tell.
Sir, please continue, sir.
Okay.
Sir, what is the cyclotorsion?
Cyclotorsion is rotation. These superior rectus, inferior rectus, and superior oblique we call cyclovertical muscles. Cyclo means rotation, vertical means vertical movement. All these muscles have got vertical movement, motion as well as rotational movement. Now, before coming to the pathophysiology, till now I have been talking to you about the pathophysiology skew deviation. Now I'm going to talk about the alternative skew deviation. Before that, you must know the connections of the anterior and posterior semicircular canal. This is very important to understand the upbeat nystagmus and downbeat nystagmus. It is one extension of that. I'll tell you one. So, what happens in anterior semicircular canal? That is connected to the superior vestibular nucleus, and then cross to the ventral tegmental tract and connect with the contralateral upward moving nucleus. Remember, superior vestibular canal, otherwise called anterior, is connected with the upward moving. Posterior semicircular canal, called inferior, is connected to the inferior moving nucleus. So this anterior semicircular superior canal or anterior canal is connected to the opposite muscles responsible for upward movement. That is superior rectus and inferior oblique on the opposite side. Let us see what happens if the superior rectus is activated. It elevates the ipsilateral eye, and the inferior oblique also produce elevation of the contralateral eye. Okay, right. Suppose superior rectus activate, what happened? That I will move upward and in dot. As you know, the action of superior rectus is elevation in torsion. The inferior oblique is activated on the contralateral side. That means that I will also elevate but extort. You got the point. What happens in upbeat nystagmus is that in this bilateral lesion, the rotational component will be cancelled out. Only the vertical movement will be perceived. Okay. So that, forget about that we'll talk in another class. So this is how the anterior canal is stimulated. So if there is a lesion on the opposite side, what will happen is it is going to conduct the same cell on the opposite side. It will produce the right condylate eye will go up and extort. This eye will go up and intort. Same, right? This is what is going to happen if both the fibers in the anterior semicircular canal is stimulated. Correct? Okay, same thing, only the other side. So if both are stimulated, what will happen? The rotational component will be cancelled out. Okay, cancelled out. Only the upward movement is same. There is a bilateral lesion. This upward movement will be gone. The other things will take overact. The connection of the posterior canal will overact and the eye will tend to drift downward. So there is a fast component upward that is resulting in the upbeat nystagmus. So what will happen if there is this is by stimulation, there is eyes more upward because both are doing the same thing. The rotational component will be cancelled out. So if there is a lesion here, what will happen? The eye will tend to drift downward and a fast compound upward. That's the pathophysiology of upbeat nystagmus. Okay. Now, let us see now, as far as this alternative skew deviation is concerned, this downward movement of both eyes is due to the interaction of the superior rectus inferior oblique. Correct? Because the muscles which the elevators decreased. So the downward movement is because of the interaction of superior, that is the other things take upper hand. That means overaction of the inferior rectus and superior oblique. That is why eyeball tend to move downward. Correct? Because the vertical action of the oblique and rectus muscles summate in adduction, the oblique muscles have only torsional effect in the adduction. This disorder results in laterally alternating skew deviation with over depression adducting eye. Now, I am sure that you are not understand that particular statement. For that, you must know a little bit about the action of the superior rectus and the oblique eye. You all know that superior rectus is an elevator. Okay, it's a best elevator in the abducted position. Okay, in the adducted position, it's a least elevator, but in the adducted position, it's an acts as an indoctor. Okay, in the case of oblique muscle, so let's say superior oblique, it acts as a depressor in the adducted position, acts as an extortor and an indoctor in the abducted position. Is it, I don't know whether I can make you understand that. This is because of the axis of the rotation of the eyeball. Putting in other words, I'll tell you, the superior rectus is what is the primary action of superior rectus? Is elevation. Primary action of inferior rectus is depression. The primary action of superior oblique is not depression, it is intorsion. Oblique is mainly for torsional movement. The vertical movement is mainly for the vertical recti muscles. The superior rectus can act as an elevator, best in the abducted position, but it can also have a role in the adducted position. Even the adducted position can elevate a little bit. Okay. On the other hand, superior oblique can act as a depression as in the adducted position, not at all in the abducted position, because that is not its primary action. That is why it's called the primary action, secondary action. So what will happen means when these two muscles are overacting, superior oblique, inferior rectus is over, that the downward bias is occurring because of the overaction of the inferior rectus, superior oblique. That both will summate in the adducted position, because inferior rectus can also depress in the adducted position, not only in the abducted position. So that will overact. That is why the adducting eye goes in downward compared to the abducting. I think it's very difficult to understand, but this is the explanation. I think putting it other way, the inferior rectus is a depressor even in the adducted position, whereas superior oblique is not at all depressor in the abducted position. So both will summate. When both are overacting, the summation for the depression is mainly in the adducted position. Mainly for the abducted position, only the inferior rectus can act. Adducted position, both inferior rectus as well as superior oblique can depress. That is, the eye is moving much more down in the adducted position. That is to say that superior inferior acts at elevators and depresses even in the adducted position, whereas superior inferior oblique can act as rotators even in the primary position. The other way around, oblique can be, even the primary can rotate, but not the superior inferior rectus, because that rotation is the primary action of superior inferior oblique. I think I'll skip this. This is the mechanism why I'm telling you why this. Why this is because the superior rectus has to deviate only 23 degrees or it become abduct, the axis become perpendicular. I think I'll skip that. It will be difficult to understand. Okay. Is it okay with you? Can you understand a little bit about the alternative skew deviation? Too tough, no? Anyway, too tough to skip them. Skip it. You're not required. Then then you get the torsional nystagmus. You know the pathophysiology of torsional nystagmus. It's again difficult to understand. For that, nystagmus is rotation of the eye beating around the visual axis. The direction of beat is better specified as clockwise and anti-clockwise rather than right and left terms. You don't say left rotational nystagmus or right rotational. It is ambiguous. So to avoid confusion, use clockwise nystagmus as in with examiner's point of view, which I told earlier. So this is the picture I showed earlier. Anterior canal is connected with the upward moving muscles. Okay. What will produce? When there is anterior canal is activated, what will come? That I will go up and in dot. Left I will go up and X dot. Okay. I'm not talking about what you want, the pathophysiology torsion nystagmus. Now imagine that this is that's anterior canal. Now the posterior canal that is going up and connected with the inferiorly moving muscles. That is inferior rectus and the superior. Both are depresses on the opposite side. The inferior rectus supplies the ipsilateral side, superior oblique supplies the contralateral side. When superior oblique is activated, what will happen? That eye will indot and move downward. The opposite eye will depress and move outward. So the movement, vertical movement is same. Both will move downward. And the rotational component is opposite side. So when anterior canal is stimulated, the eye will move up, move to the opposite side. Posterior canal is affected, I will move downward and move to the opposite side. Imagine both are stimulated. Both anterior canal, posterior canal stimulated, what happened? All the extraocular on the opposite side is affected. Okay. So what is going to result will be that this is what is going to result. That is, the rotational component will be cancelled out. Sorry, the vertical movement will be cancelled out. The rotational component is always to the opposite side. Okay. So the vertical, both are stimulated means the vertical movement, one is going to upward, the other is downward. Rotation is the opposite side. Both are stimulated, the rotational movement will summate, but the vertical movement will be cancelled out. So you get a rotary movement. So this is a slow component. So when you get a lesion here, you get a slow component to the opposite side. When you stimulate that, you move to the other side. When there is lesion, this has in the opposite side is stimulated. The slow component is to this side, same side. And that's a slow component. And a fast component to the counterclockwise. That is causing the torsional nystagmus. So torsional nystagmus is due to the lesion of the pathway involving the pathway from both anterior and posterior canal fibers to the extraocular muscles. When the vertical movements are cancelled out, then only torsional movement is persisting. I think I will skip that thing. This is the torsional nystagmus. Can we make the torsional nystagmus both sides?
Yes, sir.
Yeah, please.
Clockwise, sir.
Pardon? Yeah, right. Now, at least you remember this particular point. Okay? In medullary lesions, like lateral lesions, upper poles beat away from the side of lesion. Okay. Suppose there is a left side lesion, you get rotated component to the contralateral side. Okay. That means From the patient's side, where left lateral medial lesion, you get a past component, rotary component, the past component to the anti-clockwise. Patient side, left side lesion. Membrane lesion, just opposite. Upper parts be towards, because it's already crossed. Okay, so now what are the other things will you look in this particular patient?
Accommodation, sir.
Very good. Light night dissociation. Okay, let us see the light night dissociation. The pupil is slightly irregular but not reacting to light at all. No reaction. Okay. Now what you would like to do? Check accommodation, right? But the problem is got absent convergence. When there is absent convergence, it's difficult to check. So in fact, data convergence is not reacting, but we cannot assess because it's not convergent. Now let's see the effect of convergence. Converging, but it's not adducting, eyes are not adducting at all. So I cannot assess the pupil reconstruct intact or not because its adduction is not there. So that's the story of this patient. So this patient I in fact brought for only one purpose, to demonstrate you the alternative skew deviation and the upward gaze palsy and the pathophysiology, the Rotary nystagmus, etc. Okay. Any questions?
So the site of alternating skew deviation would be ventral tegmental tracts, sir.
No, it can. In fact, it is due to the affection of the fibers coming from the superior canal and the otolith organs. Bilaterally should be affected. If it's unilateral affection, you will only get a classical skew. Alternative skew means it has to be and bilateral should be there.
Okay, sir. So then means where the ventral tegmental tracts will move together, that is a site of lesion.
Yeah, correct. That what is exactly correct, because the fibers from the superior subsacral canal go through the ventral tegmental tract to the midbrain regions, supplying the upward moving muscles. That should be affected to produce that thing. So that is inferior bias is there.
Yes, sir.
Inferior bias is due to looking down. The muscle involved are the inferior rectus and superior oblique. The inferior rectus is classically a depressed in the abducted position. But inferior rectus also can depress in the adducted position. That is why more depression occurring in the adducted position. Because both muscles are overacting on both sides.
Yes, sir.
That is
Sir?
Yeah, please.
Sir, if he attempts to converge, the pupil should constrict, sir.
Correct. In fact, even in this even if the patient does not have a convergence, you can make the pupil constrict, provided you do not by attempt convergence. You bring that an object near to his eye. Suppose even we close one eye, you can make the pupil constrict if you bring it even without convergence. So suppose you bring your finger from a distance towards the eye like this. I don't know whether I'm looking at an object, closing left eye, and my right eye is not converging. No, I'm looking at my finger again, coming right, looking at the finger, then pupil will constrict. That's called the accommodative. That will produce the accommodation. No. That stimulus, that is sensory stimulus, the visual stimulus can produce pupil, the convergence triad. That is the constriction of the pupil as well as the contraction of the ciliaris muscle. So the accommodation reflex can be due to two pathways. One is you converge the eye. There is a proprioceptive input from the medial recti go to the mesencephalic nucleus, and that directly stimulates the lingual nucleus, and the pupil will constrict. That is the classical pathway. The other pathway is the visual path. From the vision, the visual input go to the from the lateral genital body go to the occipital cortex, then to the frontal cortex, from the frontal cortex directly come to the edicular. So utilize that pathway. So the eyes, the pupil can constrict for a near vision without the help of a contact on the medial rectus. Are you getting my point?
Yes, sir. Yes, sir.
Very
Sir,
close
can we
one.
get the reverse, sir?
Like what?
Sir, like light reflex is preserved, but accommodation is absent.
Yeah, it is there. That's called reverse ARP. That is described in lesions of ciliary ganglion. This is the reverse is there, where the opposite will occur.
Okay, sir.
So patient's MRI finding, sir.
No, in fact, this patient's this has happened 20 years back. So I asked him to bring the old MRI, but he'll be bringing it next week or so. But the idea was not to, I mean, we all know the lesion is likely to be in the midbrain, no? It's got because luckily the coleus and everything is there. But I will tell you, let you know the MRI finding next week when I get the picture.
Okay, sir.
Okay, right. Any questions? I think I can stop here because
Sir, what is this phasic OTR and tonic OTR?
Tonic OTR is the persistent position on rotating the head to the right side, on keeping the head to one side. Phasic is when you move the head, the eyeball will rotate to the other side. That is a phasic one.
Okay.
Suppose I'm doing like this, that is a phasic. Ultimately, when you remain in the position, it becomes fixed on that direction. That's a tonic liberty.
Okay.
The same, there is a principle behind doing our Wilczewski's head rotation test. Okay, because the superior oblique is paralyzed, no? So what you are utilizing the torsional action of the intact muscle to detect the paralyzed muscle. Because when you rotate on one side, the one eye will intort, other eye will extort. When one intortary is weak, the other fellow will be overacting. That is the principle behind your Wilczewski's head rotation test. Suppose I got a right superior oblique weakness on the right side. I make that weak muscle do the work. I want you to make indort that. So what like the two indort, superior rectus and superior oblique. So when you ask we want to indort, what will you do? The eye is indort mean I will tilt it to the same side. Imagine my right eye. Right superior oblique is weak. I tilt the head to the right side. That when you normally what will happen, the right eye should indort. That means the indortus in the right eye is superior oblique and superior rectus. On the left eye is extorting, that is the inferior rectus, inferior oblique. So when one muscle is paralyzed, anyway the eye has to indort. The only muscle which is indorting is the superior rectus. When superior rectus indorting, what will happen? In unopposed it will also elevate the eye. Okay. Why elevate? Because normally in ocular counter roll, there is no vertical movement. Because with both superior rectus and superior obliques acting, the vertical movements are cancelled out. The mild vertical separation is there,
Yes.
mainly cancelled. So only one is acting, superior rectus in an attempt to indort, invariably it will act unopposed and elevate the eye. So you get the vertical separation. They are more prompt. The diplopia will be more prompt. That is the principle we use in Wilczewski's head rotation test. Okay.
Okay.
Now, when you go and read this topic once again, it will be easy for you to understand. If you got any doubt, you can ask me later, no problem. I'll clarify. Shall we stop here for the day?
Sir, one question. Sir, this kind of
Questions are always-
ocular,
please.
this thing is only in humans, sir. In other mammals and all. So there like this kind of intricate control.
Well, it should be there in all these things should be there. Who have got a binocular vision is required, this should be there.
Or is it because we are bipedals and that is why? I don't know. It's
I
not.
don't know the answer correctly. I'm only guessing. It should
Okay,
be
sir.
there. Other things.
Okay, sir. Thank you, sir.
Thank you. Okay. Shall we stop? Okay. We'll see you next week. Good night. Shall we stop
Good
now?
night,
sir.
No
Yes, sir.
questions, please.
Yes, sir.
Okay.
Good night, sir.
Good night.
Good night.
Thank you, sir. Thank you, sir.
Good night,
Thank you.
sir.
Good night, sir.
Good night. Good night. Good night.
Good night,
Night,
sir.
sir.
Good night.